We're supporting data for around 7.5 million citizens, and we're processing data from primary, secondary care, and to the tune of about 1.5 billion calls on those data terminologies per day at the moment. And what we're trying to do is we're using the data that's identifiable for the citizen, for their direct care right now. If they ring 111 or a London ambulance, they call on that data. The same data can be de-identified or anonymized for population health work, and the same data can be used for research such as real-time.
Welcome everyone to the latest instalment of the Innovation in Healthcare at Curia here. We're interested in a broad spectrum of opinion in terms of how innovation is going in the health service. I'm very pleased today to welcome my colleague from the past in various ventures, Shane Tickell, who's CEO of Templeblack. And Shane, perhaps you can just introduce yourself first as to what you do in life and
Sure.
how and why we're interested in what you've got to say, I guess.
Well, thank you very much for inviting me here today. So I have two companies, and I'm chief executive of both. One's called Templeblack Quantum Health Technologies, and the other one's called Varroa Health Technologies. And what we're in the business of in Varroa is about health data and bringing it together and make use of it many, many times. And I'll explain that a little bit more. And Templeblack Quantum Health Technologies is really looking forward strategically and saying, how soon are we going to be able to make use of quantum technologies? Because I believe the size of things we need to bring together with data, such as video and others, genomics, to be able to process that in a meaningful way to change care, we're going to have to use some bigger things than exist now in our sort of cloud capabilities. So that's what I'm about today. Do you want me to go into a little bit about how we got here?
We're here to talk about data today, but the problem with talking about data on its own, it's meaningless unless you contextualize it. So how did you get there? And you've done quite a lot of work with public sector, for instance, haven't you, in the past, and the use of data, and perhaps a little bit more than we've done in other parts of the country, not far from here.
Yeah. Okay. So. Broadly, my career split into three sections. I spent 5 years working in private healthcare and in purchasing and understanding how hospitals worked and groups of hospitals and things. I spent 5 years in industry broadly and learning a lot about the commercial world. And then following a family event which involved the end-of-life care of my father, which was rather a protracted process and a rather uncomfortable one. It inspired me to see what we could use technology for to improve everything around health and care. So that was 25 years ago, 26. And in that time, I've worked with software companies primarily around the capture of data in the form of electronic patient records. And we've done pretty cool things like using algorithms for dosing people, for instance, with drugs, working out the right calculation, through to analysing the data around that patient. And over the 25 years, I've worked with very small and very large companies. Now, about 3 years ago, I stopped working with electronic patient record companies. So I was CEO for 13 years of mission critical companies that were supporting tens of millions of patients and citizens across the UK and Ireland with real-time systems, whether that's running hospitals or it's running theatres, A&E departments in the community, whatever. Now, my big passion has been around bringing together health and care data from the conception of life right the way through your needs of life through to your end of life care, and then using that data after your life as well for research purposes, anywhere it's of value. So in the last few years, to sort of achieve my aspiration, which is to broaden things out across the health and care spectrum. So that's led me to these two companies and the work we're doing today. And over the last 25 years, I've been involved in building computer systems or keeping them running or enhancing them, where we capture data and we process it a bit, and we might send people information, letters, help with the management of people, but it's not been joined up. And the big challenge of the last 30 or 40 years is actually integrating data. But I've also tried to do that for the last 25 years too, with relatively little success. So after a few initiatives, what I've realized is actually if we can take data from those systems, cleanse it, then we can make it useful for many, many things. And that's where we get to today. And the work that I'm doing with Varroa Health Technologies, we're very lucky. We're working with 3 ICSs in London. We're supporting data for around 7.5 million citizens. And we're processing data from primary, secondary care. And to the tune of about 1.5 billion calls on those data terminologies per day at the moment. And what we're trying to do is we're using the data that's identifiable for the citizen for their direct care right now. If they ring 111 or a London ambulance, they call on that data. The same data can be de-identified or anonymized for population health work, and the same data can be used for research such as real time. So we've been sending some of it to Oxford's Nuffield Primary Care Department with doing some analysis around post-vaccination work. So the same data collected once, used multiple times. And that's what fascinates me, is getting that data in, getting it cleansed and giving it to people who can do some really, really clever things.
We'll come on to look at the impact of some of the recent reports that have come out later on, but the pace of change in healthcare is frankly breathtaking. Yeah, I've been qualified as a doctor now for 42 years. And when I think back to my medical school days, we had discovered DNA. We could isolate bits of it. But nowadays, we're at the frontiers of describing every part of the genome, and the amount of data that must bring and opportunities it must bring. So I suppose, there's always a cost element to that, but to sustain these sort of data systems, what sort of investments do we need to make in a general sort of way?
I mean, I think that's a really good question, and one I'd like many people to take note of and to consider. Maybe if I can just step back from that at the moment. One of our limitations is always on. We're waiting for people to come up with strategies that create business cases, that create funds that people have to apply for. And I think that's wrong. I think that holds us back. So there's been enormous dynamism over the last couple of years with the advent of COVID, that we just rolled out some basic technology really, but en masse. And so those things will probably stay, and we'll work out, being able to virtually call your GP surgery or them to call you, or outpatients, that's great. That'll stick around now. But actually some of these things you talk about are really the important things. It's getting the data and processing and doing something with it. And I feel really, right up to this minute, there's 9 strategy papers that have come out recently. And actually the thing I hadn't realized until really recently is, because I was rather disappointed in some of them. In fact, all of them aren't ambitious enough, frankly.
Right. Okay.
And I managed to talk to some people who'd worked in the strategy papers, and I was very critical. And actually what they said was, but what you unfortunately probably don't understand is that politically and in leadership terms, people are unlikely to publish really ambitious strategies because of the risk of failure. And if they're seen to fail, then not only is it the criticism, but the lack of funds comes with that. So if we look at the whole picture, I think actually independently, so whatever your role is, whatever part of health and social care society you're involved in, here's what I've come to the sort of position of now, is don't wait for money, and don't wait for a strategy, and don't wait for other people to do things. And I think what we can do, I'm leaning towards things that are based on population cost as opposed to you get a budget. Now, there's parts of that in the system. And I think with technology, and I think with technology companies, I work with some of the world's largest technology companies, and they're moving towards sort of usage. Now that could be usage of call on the data and processing, but it could also be usage based on populations. And I think we as citizens, there is a certain allocation per head of population per annum for your care. And if with technology we can use a percentage of that, then we can fund the really difficult work, or more challenging and more interesting work, of bringing the genome and the DNA map from sort of conception, from when the baby's sort of heel pricked at birth, and start to do some analysis and work with that. And I think the pockets of funding at the moment are around, well, we've got to do some clean-up work with electronic patient records because we haven't finished those, so there's a couple of billion for that work. But all we're going to do with those trusts is actually bring them up to where others have been for 20 years. We're just cleaning up a bit. We're not advancing anything really. Then we've got a kind of let's do a federated data platform, and we're going to use that for operational needs. And I would think, well, instantly extend that to clinical needs. And then we've got the research funds, but actually one recognises there needs to be an element of research money, but if you collect the data once and use it many times, and actually we can be a lot more strategic, and once we've got this bigger baseline, then we can do some more of the the other activities?
So there's always a silver lining to a crisis, and without mixing my metaphors here, but COVID resulted in I think a massive change in the appreciation of the importance of data, the importance of public health systems, and the cooperation that's required to deliver. Now, the vaccinations is an obvious example of that, but I think there's other examples in terms of rolling out rapidly virtual consultations, etc., and making things as safe as you could in a high-risk situation. The Goldacre review is much more specific around research and is very important. But one of the recurrent themes in that is about trust. And I think that if that silver lining has to be built on, it is the population trusting people to use that data. I just wondered where you think we are with that, and are the public on board yet?
I mean, I'm a fan of the Goldacre review, and Ben and I have shared similar positives out of what we can do to get people to understand why we need the data. And I think I'm reminded of the work that's been done in One London, where they consulted over a good period of time, and they brought citizens in and got them involved. This is, to me, it's about communication. Communication with the public primarily. I think we've got it wrong at least on 2, possibly 3 occasions. And I do believe we've got to explain to the public and to the health professionals why we need this data and why we need good quality, what we're going to do with it. But I think the thing that's been missing is 2 things. The language in which we use. I think most recently, the GP GDPR grab looked like it was rushed. It probably was last minute, but looked like it was rushed, and therefore citizens got really nervous about it. I think we need to use people that the public can relate to. So I don't think, frankly, ministers are going to do it, MPs aren't going to do it, frankly I'm not going to be able to do it, but who can they relate to? And I've said people like Ben Ainsley, like Susanna Reid, people who they look at, Anton Deck, if they can explain in simple terms to the vast majority of people, but complement that with scientists and people that we really respect, then I think a mixture of that, but communicating, the openness, the honesty, what we're going to do with it. But I think was written in the recent NHS data strategy is a data pact, and I think that's wrong. I think it should be a data promise. We have to promise we're going to use the data for the right reasons, what those outcomes are going to be, research, curing cancer, curing all kinds of things, but that we're going to protect those people's data. We're not going to misuse it. We're not going to sell it to insurance companies for the avoidance of treatment in the future, and we're not going to sell it to other companies to use for marketing purposes or whatever. And we have to keep that promise. And I think it's quite easy to do, to be honest. I think it's about communication.
Sir David Nicholson and Sir Bruce Keogh used to argue that the only place you could roll out a full genome project and get the acceptance of the population was the UK, because of the NHS and the fact that it had a unified number for your NHS, and you felt that it was safe within that, and it was not led by commercial organisations. So you make a very good point. I remember when Care.Data was advocating, and I was working at NHS England at the time, and we were hoping to go on to TV and to promise exactly what you just said, and it was pulled because there was just not enough trust. And I remember about 3 weeks earlier than that, I was in a GP surgery down in Woolwich, and they were holding a patient group that day. So we went to talk to the patients about what was happening in their practice, really good practice. And I started talking about Care.Data, and one guy actually said to me, "Over my dead body, will you get Care.Data?" So the strength of feeling was
really
absolutely
palpable,
immense. And I think at that point we realised this needed re-looked at and relaunched, which was a shame because it lost us so many years at that time. I want to move into the more commercial areas now. Because a lot of people who'll be watching this are probably sitting there saying, well, how comes he got such great inroads into public services and got contracts and things like that? Because I meet a lot of entrepreneurs, people in innovative technologies, and they really can't find a route into the NHS. So, what was your journey like? How did you get acceptance, the fact that you can work in a private public sort of partnership?
Yeah, again, really good question. I met with somebody earlier today who's got some great technologies, come from a different country, and asked me the same question. They've been at it 4 years. I've been at it 26. I'm not sure I'm still getting it right. Well, I mean, in truth, it's about I do think it is exactly the same. It's about communication, it's about going to see people, it's about listening, and it's about learning, and it's about being relevant. So it isn't about creating a technology and trying to sell it. I don't know how other people measure success, and I'm not a fan of labels, so I don't consider myself an entrepreneur at all. And actually, I feel so much failure over the last 25 years more than success. I consider success in our industry to be around what I call value saturation. So you can build a great electronic patient record, but if it's only used in one department of a hospital that's got 180 specialties, then it's useless. It's only used across a community like an ICS if everyone's got access to a shared care record. So saturation means you've developed something that works, and it doesn't necessarily need it even to be the best technology or the latest. It has to be something that works and adds value today, but it has to be understandable and relatable and get it out there to people. And to be honest, I started off in this industry 25 years ago, visiting universities, going to conferences, listening, but reading 7 days a week, understanding what it is that people are trying to achieve, and adding value to that. And people often talk in the tech industry, I hate it when people say, what's the problem you're trying to solve? And part of my work, I work with Tech UK that has several hundred companies working in this industry. And the reason I work with them is because I want companies to perform and communicate as best they can, along with people being able to buy as best they can. So my foundation in learning how to buy was one of knowledge sharing. You know, doctors literally used to take me into theatres, show me what equipment they needed and why they needed it. And I used to go around the world and try and acquire the best thing for them. It's really no different. It is about listening and trying to understand. But before you solve a problem, there is opportunity. And I think quite often in our industry, we're quite lazy. We say, well, when the NHS tells us a problem, we can tell them how to fix it. And I've been encouraging, a lot of our work this year has been around helping the ICSs about what they might want to look out for and what they might be able to do to bring things together. So there is no shortcut to meeting people, listening to them, spending time with them, and having opportunities to talk and write. But you have to do your hard work. You have to study, and you never know it all. And as soon as you think you're current, it's probably when you need to do a little bit more work.
And of course, there's shifting sands because the organisations don't stay the same
Always
either.
change.
And I'm just going to come on to that. I mean, in the NHS seems to have, well, it's gone through yet another reorganisation. ICSs are now real, and we'll be doing some work on that in the commission that we're running at the moment, looking at integration. But also it's taken back in certain parameters that were external, such as HEE, NHSX, etc., are now in-house at NHS England again. And I guess, I do work on organisational readiness and looking at codes of practice to make sure that people, they know what they're dealing with when they're purchasing, they know what they're dealing with when they're providing in terms of technologies. But if you were looking at, and maybe got the ear of both the Chief Exec of Amanda at NHS England and the head of HEE, what would you be advising them to concentrate on so we can uplift, I guess, the NHS's capacity and its readiness to accept a lot of these sort of data-driven things?
Well, I think you're in two states. You've got people who are where they are right now and using the technologies that they've got. That's a little bit harder, so I'm going to come to the easier one, which is bringing people into the health and care system. I don't believe we actually do any basic really training in one, what digital means, what digital health means, what tech health means, and why it's important. And again, I think that comes back to communication. Now, I think, some of the work we've done together before, you can use virtual training to give people a really good grounding. And I think we could reach literally millions of people if we've got 1.2-3 million people in the NHS and 1.6 in social care. That's in the professional arena, but I think there's 4 million carers who are involved in care as well. And I think the public or the personal health record and the use of that, both patients and their carers, I think they should be also included in the education bit. If we look at the professional side, I think that's where your question was a lot about what can we do a lot more now. There is a difficulty in some of the systems we have are quite complex to use. So modern apps and modern access to applications that we have in our normal daily lives are pretty easy to use. A lot of it's self-explanatory. A lot of our clinical systems aren't self-explanatory, and frankly it's because they're rooted 50 years ago. And it's difficult stuff that we do. You know, pathology is really complex area, and I worked for many years in pathology computer systems, and actually I find them way more complex than a lot of our patient administration type systems. You do need specialist knowledge and understanding, but it comes from knowledge sharing, user groups, but the use of virtual training and virtual communication, we can reach an awful lot more people now. And I think there has to be a communication, which I really haven't. So you get a data strategy, but how many people are going to read that health data strategy that it actually applies to across an ICS or across a healthcare setting like a hospital? I can't imagine. I mean, and actually they're weighted tomes, you know. You've got to be pretty dedicated to go through them, and it's got to be a specialist area. But we want to appeal to nursing staff, we want to appeal to receptionists, we want to appeal to all kinds of people. And so I think we need to take an approach which gives a broad reason as to why you need to be involved, and then help make it easy for people. And the last bit we need to continue to do, try and get suppliers to make the software easier to use. We talk user-centered design, but in the older systems it's harder to do that. So I think it's not an easy answer, Mike, I'm afraid. None of these are silver bullets, but
no. But if we could produce some, you know, rapid upskilling type online content,
yes,
you know, when people can access it when they're in a zone that suits that,
yeah.
And we get away from the mandatory training. I must tick this box to make sure that I'm continuing my employment. Sure, there's mandatory training that you have to do. You know, I'm not getting away from that. But actually, if you want to make this fun, you make it so it's relevant to what they're doing in their world, isn't it? Yeah.
There's two things I'd give to you. Well, we used to train 3,000 or 4,000 people on our systems before they went live, and you can only put so many people through a classroom, and it used to take 6 weeks. And what was horrible was I felt for those people that you did the training 6 weeks out, because I'll forget 80% of that in the next 2-3 days.
Yes.
So that virtual training is just fantastic because people can do it and they can refresh. And the last bit of technology, I did a lot of work about 7-8 years ago with 3D technologies. Now the technology itself, the physical stuff, didn't work terribly well. But what I learned from the process was if you are able to use some of these, whether it's virtual reality, or in that case it was 3D technology, your memory is 80% higher than if you were reading it off a piece of paper. The retention after 2 to 3 weeks is phenomenally different. So we've got a lot to do actually with using better technologies for mass, if you like, education and upskilling those people, but for sure online capabilities.
So I want to just move on finally really into what some people still, I think, feel like a Star Trek world, which is the use of AI and artificial intelligence and machine learning. And yesterday I was recording something about robotics. And robots, we've got lots of robots, but what we're really talking about is the Elon Musk version of robotics, the one that you could not differentiate very easily from a human. And I go back to my Blade Runner days here,
right,
and worry about this. But in essence, we're starting to look at robotics that would have artificial intelligence built in and could therefore be communicative, intuitive, perhaps, and perhaps intervene. Is this a real thing, or am I just in science fantasy here?
So I think we've got to. I'm going to break this down into 3 areas, and there is a risk at the moment that the AI bubble is about to pop in some areas, especially in health. So let's break it down into sort of there's AI, there's machine learning, and then there's the application of those. And the word hype I would use a lot. So mysticism and hype. There's been a lot of hype around the capability. As with a lot of parts of any industry, 80-odd% of it in its early stages is pretty unusable. If I go back to 26 years ago when I started in this industry, we used algorithms for calculating the correct dose for warfarin for about 175 different types of condition that a human could have. And we were able to use that really, really effectively. So artificial intelligence is an upgrade on that. And it can, if we come back to some of the uses, you and I have spoken before, and actually I think your percentage is higher than mine on this. I sort of worked out about 80% of the reason somebody contacts healthcare associate doctors, GPs, is probably for reassurance, but they don't know that. They've got a lump, a bump, a sick child, an ill parent, something's changed. They ring up the GP, they want to see somebody. I think over 82.3% of everything we do needs a pathology exam, and over the 70% needs some kind of a radiology exam. So we're getting much better with pathways of saying, oh, right, these are the 5 symptoms, we narrowed it down, we definitely want one of these, let's get them done, then we'll get the patient and we'll start them on the pathway, the process, what have you. 80% of those results are going to come back and they're going to be in range, they're going to be safe, they're going to be sound. And then what we do is we focus on the other 20%. The 10% are pretty difficult. The reason that people like you have trained for decades to become really specialists at what you were in sort of clinical and medical area. And then the other 10% to get into the really tricky stuff that we can fix people with. So there's a huge potential for artificial intelligence. How do you get to artificial intelligence? You give it lots of data, that's called machine learning. And people often think they're separate, they're not. One has to inform the other. And there's a capability there. And I because I'm looking at quantum health technologies, I'm looking into the future as to how can we do this at massive scale for entire populations really quickly. And then there's byproducts of that clinical data being processed for operational work. So there is real potential, but I think what we're seeing is some of it's novelty, some of it's companies wanting to make a few quid, some of it is anti-embarrassment. I'm doing some research back now over the last 50 years of artificial intelligence, and the number of initiatives that happened by certain companies, they couldn't bury them or say we've got it wrong, they just had to let them fade over many years. And I think for me there's always a level of openness and honesty about what are we trying to achieve and what are we doing with it. So I think there is huge potential with artificial intelligence. There's huge potential to self-manage and self-care and some of those robot-type capabilities. And whatever they're presented, I know they're making meaningful change in things like mental health. They apply to a certain part of the audience, if you like. They don't apply to everybody, and we need a mixture. And some of it will be half and half. So I think if we're looking at the size of the resource problem, the waiting lists, the lack of staff, trained staff that we've got, this technology can make huge differences, but we also need to trust it. We need to understand what it's really about, and that's down to communication.
Yeah. So I think a lot of these are just examples of assistive technologies that actually, they add to what I would have done as a clinician, and perhaps make me safer. and because that when you get a diagnostic conundrum, sometimes actually running it through an algorithm type world, you're not missing some of the major symptoms of perhaps a severe underlying illness. And we know there's a great criticism at the moment for early diagnosis of cancer, and again Amanda Pritchard was talking about this today, I think it was, around the large group studies that are now going on to try and find inroads into those early warning signs and pick up. But I think data will help much more than intuition in this case now. I'm sure that's where it's going to come from. I also think that we've seen fantastic strides in radiology, in pattern recognition of radiological features, particularly in early diagnosis of breast cancer. So I think there is a great future. I'm just wondering whether we're all promised, but are we going to be able to deliver this? Is the NHS, in your view, joined at the hip but slightly more external than most, I guess, ready for these sort of changes in the use of both data and modernising digitally?
That's a really difficult question, and one that, look, in my humble experience, it's partially ready. And again, it comes down to trust, listening to people, understanding and communicating in a way that they can absorb it. So there's no one way to tell somebody how to do something. You have to communicate with them, and it has to be a fair trade. And I've seen disasters over the last 20 odd years whereby someone's come up with great ideas to rationalise, and that's not been accepted for a decade. And it's because we didn't understand that people were fearful of their jobs. Many times in my career, I made a point in my career of what I call walking the floors, walking the wards, and listening to people and understanding. So I'll give you an example whereby our system would code in clinical coding of activities of diagnosis of treatments. And in a certain hospital we're rolling this out, they had a room with 35 clinical coders in there. So great, I can save you 30 jobs there. And immediately come up with resistance. Well, hang on a minute, your computer system is going to cost us jobs. So you will get natural resistance. And I think what I used to, I learned from communicating with boards and chief execs and say, you don't lose 30 jobs. You can redeploy 30 people to do 30 different things, if you like. Of course, you're not going to get a clinical coder that's going to become a nurse overnight, but you can do different things with your resource, and actually you can enhance some of those people's careers. And that's what I think we're about with technology, is remove some of the waste and the needless reviewing of some of the results that we just know are okay and safe, and you get to a point. So we can deal with vast tracts of, I would call it wasteful resource, doctors sitting down going through basic results. And I think we can make a big difference. We know with the 6.6-ish million people on waitlist today, only 4% of those are going to probably need an overnight stay. But getting to the ones that need it, that's the big sort of challenge. And of course, if you like, the queues are gathering and continuing to go up, aren't they? So
my college is one of my colleges is a Royal College of GPs, and for the last probably 15 years we've been concerned that we don't have enough GPs, and it's gone from 5 to 10,000. And my view was always, if we're unattractive, we've got to make it more attractive. If we can't make it more attractive, then we need another plan. And I think we're at that stage at the moment, and I think the other plan might make it more attractive. But in fact, you've just described what we're really looking for now, which is your clinical leaders should not be doing the very basic, mundane back of house. And to me, if digital technology is going to help us with anything, it's taking the mundane away so people can concentrate on the difficult, wicked problems that medicine throws up.
There is one thing, you did say safety before, and I think we burden some of our staff too early in their careers with really serious decisions that do cost lives. But fundamentally, that's not shroud waving, it's a fact. And actually, a lot of really good technology can avoid so much of that. And it should. It's not a really good use of their time either. So that's a really important one.
And if you're looking at maternity, which is a big issue at the moment, and you look at how digital systems would help that, and some colleagues we worked before at a company called C2AI, they use a very invasive data approach to look at risk, particularly for post-operative care, for pre-operative care, for the prediction of sepsis, and also the prediction of whether your unit is safe or not. And if we could get systems, they're not unique, there are other ones as well, if we could get systems like that in place to help clinicians and to help regulators, because regulators have to become very savvy about how they use the data as well, so they're getting the right messaging to when they go to inquire within an organisation. Shane, thank you for your input today. Is there anything I haven't asked you about that you'd like to bring up?
I probably mentioned quite a few things, but I think don't wait is my thing. Don't wait for somebody else. Don't think somebody else has got the answer. Whether it's standards, whether it's funding, whether it's a strategy, I think most people know where the problems are in their daily work. And I think inquire. And I think don't be put off by asking the question. Quite often people, I find in all kinds of aspects of our work, is they're frightened to ask a question because they're frightened to offend. And they're frightened to offend people who they might think are more senior or more clever, or perhaps they don't want to look stupid themselves. I've never feared looking stupid by asking the right question. And I've learned so much. And throughout my career, I have been blessed by, whenever I've asked a question, I have to say, people have offered me their knowledge freely. And as I offer mine, don't be frightened to ask. If you have a thought, share it. And I'm talking about from the front line up to the absolute board level, because I do fear actually some of our leaders are perhaps frightened to ask some of the questions.
I think that's a very good point, a good conclusion, and I would ask the politicians to follow that lead when they come to look at how they're going to implement healthcare. Thank you very much again.
Thank you very much. Thanks for the opportunity.